Hello, everyone. This is the recording that I promised you guys for chapter 36. And as well, I'm going to give you a recording on chapter 37 on bowel elimination. So, chapter 36 is urinary elimination. So, what we'll do is we'll talk about um, just that basic function that it's a human basic function of urinary elimination. And urinary elimination really comprises a lot of illnesses and conditions and that type of thing. So it's very, very important for you as a nurse to assess um, urinary tract and bladder emptying. So sometimes when a person has some type of acute illness, there may be a necessity for a person to catheterize them so that they can monitor their urinary output. Um, some people might even require what they call a suprapubic uh, catheter that's a long dwelling catheter. Maybe they have a problem where they just can't empty. Maybe they need some type of diversion catheter to empty their bladder. And it's very important that a person doesn't have urinary, where they basically have their urine is um, without emptying, problems with retention, more or less, and that type of thing. So, what we'll do is we'll start. Okay. Um, there's a movie, and there's just it's a little parody. I'm not gonna discuss the parody, but you can look at it on the actual video, just not the audio. The purpose of this is for me to basically go over, the things that I think are important that you should know about urinary elimination. So we'll just skip the parody. Okay, so first of all, in order for you to be able to uh, correctly assess the urinary system, you have to know what the basic parts of your bladder, of your urinary system, what it uh, comprises of. So you have the kidneys. Everyone knows what the kidneys are, laying on the vertebral column behind the abdominal peritoneum and against the deep muscles of the back, level with the 12th thoracic and third lumbar vertebrae. Now, normally, and this is important, the left kidney is higher than the right because of the anatomical position of the liver. Um, so the kidneys remove waste from the blood to form urine. The nephrons is what they call the functional unit of the kidneys, and it removes waste products from the blood. And it also plays a great role in what we call fluid and electrolyte balance, and we'll get more into that when we discuss fluid and electrolyte balance later on this quarter. Each nephron contains a cluster of capillaries, and the capillaries are called the glomerulus. Um, and so the glomerulus filters water, glucose, amino acids, um, uric acid, and major electrolytes in the body. So if a person has like injury, maybe they got injury from trauma or something like that, um, you'll have proteins and blood cells and that type of thing that filter primarily through the glomerulus. And so if you see somebody and they have protein in their urine, which they call proteinuria, or they have blood, which you call hematuria, is found in the urine, you can suspect that that kidney is very, very um, injured. So not all glomerular filtrate is excreted basically as urine. Some of it is 99% is reabsorbed into the plasma. So and only 1% of is excreted in the urine. So kidneys normally produce between a liter to 2 liters of urine a day. So the ureters, which come directly out of the kidney, which transport urine from the kidneys to the bladder. Um, and basically, obstruction of the urine flow from the ureters can cause a black backflow of urine. So, like, let's say a person has a kidney stone or something like that that's blocking the ureters. So, and that can cause distension as well, hydroureter or hydronephrosis, infection from this stasis, and in some cases, it can cause permanent damage to sensitive kidney structures and function. So you got to make sure that the ureters that lead out to the kidney that goes towards the bladder are unobstructed. So one of the main things, like I said, that can obstruct the ureter would be kidney stones, and they're very, very painful. So the bladder, once the kidneys and you have the ureters, and then the ureters flow to the bladder is what they call the reservoir for urine until the urge to urinate, when the bladder gets so full up. Um, the bladder is the reservoir for the urine. Uh, and so like for instance, I did share with you guys that my father had bladder cancer and they actually had to take his bladder out. So you can imagine that that was a pretty serious surgery. And it rests against the rectum, and the in the female, the bladder rests against the uterus and the vagina, and the bladder, it expands as it fills with urine. And sometimes, if they have some type of ailment or something, and they have to, like in my father's case, they'll create uh, they'll remove the uterus and the bladder and create a path for the actual urine that's being made for the kidneys to have its own reservoir, and it'll be um, on the outside, and we'll get you know um, I'll talk about that a little bit later. So then from the bladder, you have what they call the urethra. And I just want to make sure that you guys do not forget about the difference between the ureters and the urethra. Okay, so the ureters, they come from the kidneys and lead to the bladder, and then the urethra that comes from the bladder travels from the bladder, and it go and exits through the urethral, basically the little meatus. So that is the part that you insert a catheter in, the urethra. Okay, so in order to empty out the bladder. Okay, so just you knowing those little parts, that's pretty good. Okay, so here as is in your book, on page, I guess, probably about, for me, for my hardback book, it's on page 952. You have a picture here of the adrenal gland and the kidneys and the orifices of the urethra and the ureter and that type of thing. So, and it's just basically a picture so you can visualize it because some people need to visualize it in their head. Okay, so a patient with a long-standing history of diabetes mellitus is voicing concerns about kidney disease. The patient asks the nurse where urine is formed in the kidney. The nurse's um, response is, of course, the nephron, which is answer C. Um, uh, we have this case study, and this is of Mrs. Valerio, and she's a 75-year-old woman who has been in the hospital for approximately, you say 4 days or so. And because she has heart failure, she got fluid retention, and she has diabetes. So you can see where this lady is relatively sick. And she has a history of urinary retention, which means that she's retaining urine, and that's related to her diabetes and her neuropathy. Mrs. Valero's indwelling urinary catheter was removed 2 days ago and replaced within 12 hours because of frequent small volume voiding of less than 100 milliliters, frequent episodes of small volume incontinence and lower abdominal pain, and a post void residual of 600 milliliters. So we're going to start what they mean when they say post void residual. They mean that that is what this particular woman is holding in onto after you catheterize her. So she's not emptying her bladder fully at all. So, okay, so we'll just give you a little bit on her. So, act of urination. The act of urination, and some people call it micturition, micturition, and they call it voiding. That is a bladder function where the brain tells the bladder to contract, and then the urethral sphincter and pelvic floor muscle basically relaxes. So stretching of the bladder signals the micturition centers in the spinal cord, and then that impulse goes to you, and for the center in the brain, it responds to or ignore this urge, thus making urination under voluntary control. When a person is ready to void, the external sphincter relaxes, and then the bladder contracts and the bladder empties. So that's something that tells you that in your brain. So that's if you think of it in a really easy way, you could think of it in terms of, children when you're in that process of toilet training them, you're actually working with them to pay attention to those signals or those urges that is in their brain. Um, so there are a lot of factors that influence um, your ability to urinate, and those factors uh, are listed here. And their growth and development. What that means is that children cannot voluntarily control voiding under 18 to 24 months of age. When myelination is complete, um, you have to talk about things in terms of readiness for toilet training. Then older adults may experience a decrease in bladder capacity. Um, and an increased frequency of bladder contractions during bladder filling. In older adults, they may have an inability to hold their urine, um, and the urgency need to void usually decreases, and that leads to incontinence. There are socio-cultural factors. Culture and gender norms may vary. Um, and there may be an expectation for people as far as um, the toilet facilities to be private. Religious or cultural norms may dictate who is acceptable to assist in elimination practices. And then there's social expectations, like, for instance, people taking breaks or whatever that can influence, urinary uh, influence that. There are psychological factors. Sometimes people have like a urgency to urinate and increased frequency avoiding, and it may be related to stress, or a person may have a relaxation of their sphincter muscles. Uh, Depression can decrease the urinary continence. Personal habits. If a person may feel that they have a need for so much privacy, that can really influence their ability to adequately empty the bladder. And then things like fluid intake and that type of thing, how much they urinate. A lot of times, people, I know, individuals may tell somebody something like, don't drink no water prior to you going to bed because it'll make you get up, or and like we could just get on, for instance, down here, it says medication. So, if you're taking a lot of diuretics and that type of thing, it can increase your urinary output. Some uh, drugs and stuff like that, like what is that? Pyridine can that's antispasmodic. It makes your urine orange. Anticholinergics, like oh my gosh, I don't know what, like atropine, for instance, may increase the risk for urinary retention, which means it makes you stop urinating. That's why a lot of times, sometimes if they use certain things, doing or sedatives, for instance, uh, or that type of thing, doing surgical procedures, for instance, and that kind of thing. That's because a lot of times anesthesia and all of that make a person not necessarily urinate. That's why a lot of times after surgery they'll stop. They really monitor because they don't want you to have urinary retention. It slows down. And then diagnostics, sometimes injecting uh, different things may risk infection, or you may have some type of bleeding post, depending on what type of procedure. So there's just like a lot of little different things that would influence how you urinate, the expectations of urinating, and that type of thing. So Sandy notes the urinary catheter was removed. Remember the lady, Miss Valero, that we had talked about earlier? And they said that they noticed that she had only dribbled a little bit of urine. And so, oh, the healthcare provider decided that they were going to do an intermittent catheterization on her. And the registered nurse on the day shift catheterizes Miss Valero at 3 p.m. when the catheter basically had been removed around 7 a.m. And then they noticed that she had 400 milliliters of pale, clear yellow urine. Okay. So she had been retaining some urine. So, common urinary elimination problems, of course, one is urinary retention. Urinary retention is an accumulation of urine because of the inability of the bladder to empty. And we've talked about just a second ago the types of things that could inhibit. So I want you to think about it like that, a person's ability to urinate. Urinary tract infection may result from overcatheterization. They don't even use urinary catheters indwelling like they used to back when I first became a nurse. They used to use urinary catheters all the time for people just because they're incontinent. And they noticed that the risk of infection, because you're introducing the catheter into the individual, is more of a risk than just using it. And like than letting just making sure you try to train them in toileting, and you may have to just clean the person if they have accidents. So, urinary incontinence is involuntary leakage um, for a person and that type of thing. So, um, uh, and that type of thing. And then they have urinary diversion of urine to external source. And that's what I was telling you guys, that patient who have like a bladder removed, which my father had, which was a cystectomy because of cancer, which was his case, um, um, requires procedures that would basically, they may have a stoma, or they may have some type of urinary diversion device, like my dad had, which he has a urostomy, or another word for that is ileoconduit, where they basically takes like a little tube, and you just have a little bitty opening. It's real little coming out, and then you have to put a little bag, and he does have to uh, I have to rather put a bag, and it catches the urine, and he just empties it. But that's what they do. So yeah, that can be pretty rough. So here is a look. My father looks more like the person on B uh, in terms of the little outer. He doesn't actually have like a stoma because they actually, you know, yeah. So as Sandy prepares to assess Mrs. Valerio again, because remember, you guys, she got that 400 milliliters and stuff out. She remembers that the urinary problems are common in older adults who have diabetes. Remember, I told y'all about that. So, age alone does not cause incontinence. She recalls that patients with urinary retention sometimes leak or dribble urinary and are then misdiagnosed as incontinent. She knows that patients generally void at least every 6 to 8 hours, and that Mrs. Valerio's recent catheterization has decreased mobility, and her history of diabetes makes her more prone to urinary retention. So, and she'll have a little bit of incontinence, a small amount of urine, and a possible urinary tract infection. So, what I want you guys to do is I want you to make sure that you're quite aware of the differences of the types of urinary incontinence. So you will be able to acknowledge what they are, and you'll be able to understand whether or not, there are things that possibly there's a type of actual incontinence, because you don't want to, what I'm saying is, you don't want to overdiagnose someone and say that somebody is incontinent and they actually aren't. So listen to what I'm going to tell you. There's 4 different basic types that I want you to be able to identify. Transit incontinence, transient, TRANSIENT, incontinence. And it's incontinence caused by medical conditions that, in many cases, are treatable and reversible. So a person could be incontinent because maybe they have a UTI. That's something that's reversible. Maybe they have acute delirium. They're a little bit confused. Maybe they're depressed. Maybe they have acute urinary retention and may dribble. So that is stuff that could possibly be reversed. That's transient. Functional incontinence is loss of continence from causes outside the urinary tract, usually related to functional deficits such as altered mobility, manual dexterity, environmental. So maybe the fact that that person uh, is has a problem with vision and maybe possibly having problems getting to the toilet, on time, or maybe that person has an altered dexterity. Maybe they have arthritis or a fracture, or there's things in their way in their pathway that's keeping them. So when you think of functional incontinence, think of some type of barrier that an individual is having that's making them be more prone to having kindness. Not that they necessarily don't have the urge or that they're not trying to get there. Overflow incontinence is basically um, when there's something going over, like they have a distended bladder, a lot of residual, maybe a person pees at nighttime, they're not emptying their whole total urinary bladder for whatever reason. So that makes it where they don't have bladder contractions, or they have an absent bladder or something like that. So what is good to do is probably time void them type of people, or the person may have an intermittent catheterization. And then lastly is the stress of urinary incontinence, and it's involuntary leakage of small volumes of urine related to either urethral hypermobility or incompetent urinary sphincter, which means that the muscles are relaxed. And like after childbirth or radical prostatectomy or some type of surgery or something like of that sort. So just kind of be aware of those four type. um, I'm telling you in advance. Okay, so a healthcare provider may suspect that a patient is experiencing urinary retention when the patient has what? Large amounts of voided urine, pain in the suprapubic, spasms, and difficulty, small amount of urine voided 2 to 3 times per hour. It would probably be D, where they have the lack of trying to do that. Critical thinking, synthesis, knowledge, experience, attitudes, and standards are very important things for a nurse to be aware of, how they're dealing with those type of things, and that make sure that you know the difference between those. Um, Sandy knows, let me see, that she will need to assess whether Miss Valeria feels the urge to urinate, and she realizes that nobody has really been taking Mrs. Valero to the bathroom. Um, So basically, Sandy palpates the abdomen over the distended bladder and causes some discomfort, and that the patient often experiences an urge to urinate. Miss Valera grimaces when her abdomen is palpated and says she has a little pain. Sandy knows that she will need to assess whether. Okay, wait a minute. I'm sorry. So, nursing history. You're gonna do the assessment. You're gonna um, talk about whether or not the person has a pattern of urinary. When does that person, do they waken over the nighttime to urinate? When do they mostly void? any symptoms of any type of urinary alterations. You want to know about that. And you want to know about those various types of symptoms and stuff like that. And whether or not someone has those symptoms or anything like that. For it, like, are they having pain? Is it related to privacy? Is it anything that has to do with gender factors that are affecting their voiding? And then, of course, you guys, y'all always got to know that you always have to give older people adult considerations, like their ability to get what is their physical uh, uh, purpose. Are they able to get to there in time? It may not be that they're actually trying to say, well, um, I don't feel the ability, and I can't control my urine, but just the fact that maybe their sphincter is a little bit more relaxed, and as soon as they hear that urge, they have to get to the toilet, and maybe by the time they get there, they run out of time and that type of thing. So you have to assess a lot of little different things with people's patterns and how they void when you're doing the nursing So, with the case study, the patient is able to palpate bladder, indicating bladder distension. During palpation, patient states she has the cessation of bladder fullness. And patient complains of dribbling frequently and being unable to urinate. What are the specific assessment activities that produce these findings? Okay, so you want to know what are the specific assessment activities? What other things did you do? Did you do it via Doppler or bladder scan? Were you able to, like they said, palpate? Is the person um, having difficulty getting around, or if the person's immobile, or we um coming in to toilet them frequent enough, or uh or they having accidents because everybody just like by the time they get there, if she taps on the call light, it done happened already by the time a person comes. So all of those type of things, or they embarrassed, they don't want someone to see them urinating. They concerned with their privacy and that type of thing. Sometimes people, the setting is not right. You know what I'm saying? Some people, you have to, maybe put them in a better setting in order for them to urinate. Do they have any other type of problems? Like for instance, a man, or do they have a possible enlarged prostate? All these type of things are things that you assess. So you are gonna assess all these things. When you do uh, the physical assessment, you're gonna do, like, remember when we was in lab, how you hit the back of uh, the flank area to see if they may have a infection or anything, or inflammation. Is the bladder distended? Are they retaining? Are they having problems like an infection? Or do you see an inflammation or lesions that's causing them discomfort? Is there any redness around the perineal area because they have been incontinent so much? So there are things that you can check that, okay, and see if a person is so then let's say you get where you are and you want to assess the urine. You would assess the intake and output. Um, you're supposed to urinate at least 30 mils per hour, and that is really low, on the low ball. So If you come back and it's been 3 hours and the person ain't done about 100 meals, you know there's something, and that is like not a lot. That's just like the little urinary cups filling it all the way to the top in 3 hours, then that's something you're going to be looking for. So you're going to do intake and outputs regularly. Maybe they're having a lot. That could show you a sign of possible diabetes, because that's one of the symptoms that a person has a adrenal problem, or they may have some type of diabetic problem is they have polyuria. They go to the urine, they use the toilet a lot, and when they use the toilet a lot of times their urine is very, very clear. It has no color. So they're just emptying, you know? So then when a person does and you do assess their urine and that type of thing, you want to make sure that um you look at the cat look at the characteristics of their urine. Okay, you want to look at the color. Is it pale? Is there straw to amber color? The clarity, is it transparent, or is it cloudy? Is there a strong odor? Is there hematuria? And you want to do specimen collection. So you're looking at these symptoms. You want to know if a person is has urgency, if a person has dysuria, which is pain, frequency, hesitancy. I told y'all about the polyuria when I was talking about the diabetes. Oliguria, which is little urine. They may have some type of kidney dysfunction or failure. Nocturia, or they have during the night a sudden urge of uh, um, dribbling and that type of things. There is a chart, a table, and the table has all the little different descriptions of urinary alterations. I want you guys to make sure that you take a look at that table. And when you take a look at that table, I want you to look at the diagnosis. Make sure you know what all those words mean. And I'm pretty sure, just knowing them, because I was calling them out like dysuria, oliguria, and that type of thing. Like oliguria is diminished or lack of urine output and that type of thing. The words are like very easy, like urgency. What do that mean? That's when you have that feeling like you have to urinate. So I want y'all to look at that chart, and then I want you to put it together, and I want you to make sure that you are able to see and that you are able to identify what type of things are the reasons, because they'll say common causes next to it, you know, uh, like urgency. If you got urgency, you got a full bladder, you might have a urinary tract infection. How many of y'all have had a urinary tract infection before and it make you feel like you want to pee? Okay, inflammation of the bladder. You may have a condition called overactive bladder. All of those things make you feel urgent. Okay, and I want you to take a look at those things, and I want you to make sure that you you know it makes sense in your mind to you. So also when you do your assessments and stuff, there are various things that you have to assess, and these things that you assess are questions and things that you ask yourself when it refers. Like I talked to you about urgency, um, so you want to think about things like, or they, you want to assess their urinary intake. You want to assess, do they have a lot of caffeine, a lot of soft drinks, things like that? or and that type of thing. So you want to look, are they on any fluid restrictions? You want to ask those type of questions because you're trying to line everything up together. All right. So then you do the urine testing and you collect the specimen. Um, Usually, you can check in a urine hat. If a person is able to get up and actually void, you could take the specimen out of a urinary hat, or you may have to collect it via catheterization. Okay. Um, you can empty it out of a urometer when you first put a catheter, and that's kind of like what we call like a little Foley bag, but they call it a urometer. There are pictures of them, and I want you to take a look at that. So there are various different types of laboratory and diagnosis testing. You can do a plain urinalysis, a plain assessment when you're assessing the urine, a plain excuse me, urinalysis is basically just that. Uh, it assesses like the characteristics of the urine. It'll assess the color, the clarity, uh, and that type of thing. If there's any bacteria in there, and it's pretty, just self-explanatory. If there's any blood in there, you looking at it, okay? So it'll assess like if there's protein, the pH, specific gravity, and white blood cells. So that's the type of things that a plain urinalysis will assess. And then you have various timed urine tests. Timed urine tests or things like, for instance, if a person is assessing somebody, maybe they might want to see if there's glucose, and they may do it 2 hours after a meal and then wait and then take some more to see just how much. But now, or they may be looking for how much creatinine clearance, how the kidney is functioning, and they may give you what they call a 24-hour urine test. The 24-hour urine test, a person voids and you start timing, and then you start putting it in the bucket after that first initial void of the morning, and then you stop. So you want to assess that. Um, Clean catch, where you do back to front, and what they do is they let a little bit trickle and then they put it in there. And then the urine for culture and sensitivity, you can actually get that out of a urinalysis. And the purpose of the culture, so you'll see sometimes it'll say urine CNS. The purpose of the culture and sensitivity is strictly to test a urinary infection of some sort. And they run the culture and sensitivity because they want to see what type of drugs they can actually test um, for, or will be this whatever bacteria that you have in your urine will be treated and cured by whatever drug. So when they do the CNS, which is the culture and sensitivity, it'll come up and it'll say, okay, this person has X amount of bacteria. This bacteria is called this, and these are the drugs that you need to treat to get rid of that bacteria. And then there are various diagnostic examinations. There are a lot of different diagnostic um, procedures that they can do to assess your urine. They Most of them are kind of invasive and just a little bit. So you have like some non-invasive procedures, like you have like a kidney, urethral bladder, or a CT scan, and that type of thing. Um, and they're basically just imagery. And the purpose of, like, for instance, a CT scan is they're actually looking at like a cross section of various images. So they're looking for like abnormalities like tumors and cysts. And abdominal, like a KUB, uh, which um, they do on people, they're looking at like size and shape. Like, for instance, they can use that to measure uh, the size of urinary calculi, or what we would call stones. So KUB is they looking at stones. They already know that there's stones there. And then the CT scan is you trying to find it. The IBP is to detect and measure tumors, and also urinary calculi as well, but they get a better look because they inject dye. So you have to make sure that when you are assessing and treating people, you assess for allergies, preferably like to fish and iodine and that type of thing. And then you have the ultra sounds, which detect the actual uh, um, masses and various things like that. And also, it can measure like if a person is retaining urine, post urine residual. Um, I just want y'all to be aware of the various teachings. Like, for instance, when I said IVP is, you got to really think about the seafood and the allergies to the iodine and that type of thing. And how you prep. And like, for instance, after you get finished, you always encourage that person to drink a lot of water so that they can make sure they flush out their system really good. So, all of these nursing diagnoses that apply to an individual that has functional urinary incontinence, reflex urinary incontinence, stress. But you have to know, remember, I told y'all what functional, reflex, stress, and urge, and all of those, what that mean. And then there's risk for urge urinary incontinence, risk for infection, toileting. So there's a lot of little different things that you could put that are adequate nursing diagnoses for a person that's having problems with their urine. That's the reason why when we do nursing diagnoses with you, we always say that you can have a person and you can make up all different types of nursing diagnosis on people based on what's going on with them, all the way to from the middle, emotional, uh, uh, lack of preparation, toileting problems, uh, emotional. I mean, you could just go on and start a nursing diagnosis and try to help somebody. So you plan, you always make sure that your goals and outcomes are realistic for that particular person. Don't just put some old generic stuff down there. Make sure it applies to that individual. So for instance, for that lady that we had talked about earlier, Mrs. Valero, she had urinary retention related to weakened detrusor muscle and recent removal of indwelling urinary catheter. That was her nursing diagnosis. So she's retaining urine, and it's related because her muscle is weak, probably because of her age and the fact that she has diabetes, and then also because of the fact that they removed the dwelling urinary catheter. And so your goal is that within a month you want her to have normal micturition. Remember I told y'all another word for that is basically her ability to urinate. Micturition. That's another word for that. So and then so you're gonna try to establish that goal and you wanna have her doing X, Y, and D within 1 month and you're going to set goals for her in order for her and they're going to be reachable goals and I think a month was good for her. So health promotion, you're going to do patient education, you want to maybe do elimination habits on her like toileting, like time toileting, make sure she has adequate fluid intake, promote complete bladder emptying by making sure that you might want to use a little bladder scan, ultrasound on her to make sure that she's adequately emptying it. You want to prevent infection. So you want to get this type of lady. You don't want to be intermittently catheterizing her all the time. You want to get her up. You want to get her going. You want to actively toilet her. You want to limit her taking in fluids maybe 2 hours before she go to bed or something like that. You want to get active on her. Right here, we have pictures of various type of urinals um, for men. Um, so assist with toileting every 2 to 3 hours. Instruct the patient to record urinary output if that patient goes home. Have Mrs. Valero take a warm bath if unable to uh, um, void and have her use the double void method. Let her void and then come back a little bit later. I mean, a very short period of time and have her void again. Um, so we got catheterization. You have the invasive type, intermittent indwelling. Um, when a person is you remember the Foley catheters, you guys, that we have. You got straight catheters, um, and you should pretty much know what a catheter is. Um, they have we already went through that and showed it to you, and I'm sure Erica is gonna show you some various types of catheters that you have. Normally, adults um, 14 to 16, somewhere within there is the size that they do, and anywhere between a 5 to a 30 milliliter balloon. I wanted you guys to make sure that y'all look at those videos that I posted because y'all will get a very good look at what the catheter really looks like. Um, Short-term catheter use is less than 2 weeks and long-term is greater than a month. Here they have types of catheters, and I want you guys to make sure you just take a look at these catheters. Plus, you'll see one up close and in person when Erica shows it to you in lab. Okay, the catheter size. Right there, it says 20 French, 30 cc. We use milliliters now more. CC is kind of like old fashioned. You'll hear me sometimes slip and say CC because that's what I'm accustomed to using. But 30 milliliter balloon is a really big balloon, and the purpose of that balloon is to hold that catheter in so it won't slip out of the urethra. Okay, so it's sitting in the bladder and you don't want to slip it out the urethra. You'll have a little bitty baby or a kid, and they have little bitty balloons. You know, they have the 5 milliliter and less. Where adults usually generally, I see more 10 milliliter balloons, but for a lot of times for older people or for women who've given a lot of birth, you might see them have that 30 milliliter balloon. I've actually seen older people who don't have that tight sphincter. I've had them walk out of a 10 milliliter balloon before, and it be like laying on the floor with the balloon still inflated and stuff. I mean, it's like really wild to see. So this is an actual look when you put that through the catheter through the closed drainage system, and you put that catheter through there, see, and it's locked, and the balloon is, inflated, and the part where the red arrow is, it shows that that's where you inflate the balloon. So routine catheter care, you want to make sure that you wash it with soap and water daily while it's dwelling and stuff, and keep it clean. Here is a picture right here where it says B. Remember I was telling y'all about the suprapubic kind of catheter and stuff that people will have that goes directly to the bladder. So there are people that have that. The main thing I would say about this is to keep it where there's, because it's like around the catheter where they inserted it. A lot of times it be like a little plate, and you want to make sure it's free of infection around there. A lot of times you'll see where they had it sewed in, where it kind of just be sewed in. You got to keep that area really clean. You have condom catheters, and it's actually just like those. They work like crap, you guys. They fall off. It's they're really for somebody that's really immobile. So it's good in order to not be sticking the catheter up the male urethra and causing a chance of them catching an infection. But if it's somebody that's moving around a lot, something about them condom catheters, it's not the best thing, but it's really good for somebody that's immobile. You just got to make sure that you place it correctly, the right size, and leave a little bit of slack, just like when you put on a regular condom. Okay, so you see how they got the tape and all of that trying to keep it on. So yeah, that's something. And then I told you guys about, I even went over this early about the pouches and the continent diversions. And things. So they usually have Kegel or pelvic muscle exercises that you can do to tighten it so you won't be incontinent. A bladder training schedule. I told y'all about the external pouches. I told you guys actually what type of pouch my father had. I told y'all about that early. Okay. Then there are various medications, anti-muscarinics. Um, those are medications that they give people so that it can stop them from urinating so much or and stuff. Uh, uh, and mirror background is one of the main ones. And I'm gonna tell you what it does is because it's slowing everything down, you guys. People tend to have a dry mouth. And that type. Okay, sorry about that. People have a dry mouth sometimes. Uh, People will also get blurred vision, constipation, and sometimes you might even see some type of mental status change in older people. So you just got to make sure you're careful with the medications, and you have to evaluate because you know how I feel about old people. I tell y'all all the time, to me, less is more. So And then you're gonna lifestyle changes, bladder training, toileting schedules, intermittent catheterization, which you really got to be careful with that because of infection. Sometimes you have people who may have MS or something, and they actually teach them to characterize themselves, and them people have a lot of problems. Some of them stay on antibiotics. It's almost like it's part of their therapy because they colonize, because it's like, you know, because they're catheterizing themselves like four times a day, every 6 hours or something like that. It's wild. So you evaluate, of course, you guys, you always evaluate everything that you do. And the reason why you evaluate is simply because you want to make sure that that individual, what you're doing is working for that individual. So afterwards, as far as the case study that we did on Miss Valero, I want to uh, tell you the things that happened. They did time voiding on her, oral fluids, they assessed those, and they used double voiding, and they made sure that they palpated her bladder and was there to assist her um, on the commode, and they also used the bladder scan to make sure that she didn't have any residual. If there's anybody that is getting ready to go to clinical or whatever, they need to make sure that they try to see if you can get with somebody that's going to do a bladder scan so you can see it. It's real interesting to look at. So, so this is the things that she said to Miss Valero about her to log her elimination, her INOs, and tell them about what the within that 1 month period of time about any type of complications or anything, or if she's having any lower abdominal pain, which what she was complaining of earlier. So, and then you just need to think about what type of teaching strategies and things that you need to use. And you don't have to try to be sophisticated. Think of just normal things that you would do to teach her, help her get on her schedule, get involved with her family members. If she's self-conscious about certain people, she may have one person there that's there to help her. So basically, when you use various things and you're getting ready to catheterize a person, you got to make sure that you identify the patient's risk for latex allergy or betadine allergies, because that's very important, because those are the things that you're going to use when you're catheterizing a person. So other than that, those were just the actual little tidbits that I had that were left, as far as the urinary system. And if you have any questions before the test, feel free to shoot me an email, and make sure on my blueprint that you know all the things that I have on that blueprint, and make sure you have the answers and know the rationales, and you should be fine. Okay, thanks.